Hi, how's everybody? I presume some people I know, some people I don't know. But for those of you that I don't know, my name is Liz Higgins, and I am one of the stem cell transplant coordinators in St James's Hospital in Dublin. My background is nursing, and I've been working in the area for a lot of years. And I'm just going to talk you through the process, the practical bits of stem cell transplantation and what's involved in it, really. I'm very much aware that there probably are some people in the audience that have had a transplant, so you're probably more the experts than I am. I'm really only giving you my experience of seeing people go through it, so please feel free to make comments and just join in the conversation. Okay, so I actually appreciate, I know we're probably kind of stuck for time as well, so I'll try and be as quick as possible. Okay, so why do we do a stem cell transplantation? And the type of transplantation I'm talking about is cells where we're using your own cells, basically. So really what we're doing is to facilitate high-dose chemotherapy. And I'll go into what I mean by that in a little bit more detail in a few minutes. And for some of the solid tumours, like some of the testicular cancers, we certainly would do an autologous stem cell transplantation for multiple myeloma and for lymphoma. And there would be the main three disease categories. The one thing I will say is that you see the way I have the word rescue wrote down there, because we're very much conscious of the fact that the word transplant can be a little bit terrifying. And this type of process, this type of treatment really is more of a rescue than a transplant. And again, as I said, I'll just explain what I mean by that as we move along. So why do we do stem cell transplantation for patients with myeloma? Well, certainly it absolutely, without any doubt, we know it improves the overall survival and the length of time that we can keep you in remission. And obviously the longer you're in remission, then the hope is that some of the new drugs that are there ready to be licensed or nearly being licensed will be available if and when your disease relapses or progresses. So what's involved in the process? Well, what we've got to do is, we are talking about giving you high doses of chemotherapy. So when we give you high doses of chemotherapy, we inevitably will probably destroy or nearly destroy your bone marrow, which is your factory that makes all of your blood. So what we want to do then is take away some of your bone marrow in advance, because obviously you can't sustain life without bone marrow. But if we can take away some of your bone marrow, it allows us to give you high doses of chemotherapy. So enough of chemotherapy that we hope will control your disease or keep your disease in remission for as long a period as possible. Don't worry too much then about the fact that obviously we know it's going to have an effect on your bone marrow, because we've taken those cells from you and we can rescue you with those cells, if that makes sense. Okay, so if we just look at the Irish transplant setting, I suppose, there are 3 centres in Ireland, in the Republic of Ireland, that do this type of transplantation. Galway University Hospital, St Vincent's University Hospital, and ourselves in St James's. And St James's we would do that as a shared care facility as well. So we would have a huge amount of referrals from all over the country. But we also link in with our colleagues in Beaumont, in Tala and in the Mater. And that is a shared care experience. So really what we are just doing in St James's for those 3 hospitals is we're facilitating the process. So we would take the stem cells, we will store the stem cells on site in St James's. The referring centre will do the chemotherapies and nurse the patients through their transplant, and we would just reinfuse the cells back in St James's. Galway will do all their own patients there. They will certainly take some referrals from Sligo and Letterkenny, Donegal, and they are now taking some referrals from Limerick as well. And St Vincent's Hospital, they will do all their own in the catchment area for Vincent's. So we would take referrals from all over the country, so Waterford, Wexford, sometimes we get some patients still from Cork, with very few. And then all the Dublin catchment areas, the Midlands, and then Drogheda, and sometimes we're still getting some referrals from Letterkenny. So this is St James's Hospital, the entrance to the hospital. For those of you who don't know it, I'm sure a lot of you are probably very familiar with it. And really what I'm going to do is I'm just going to talk you through how we do the process in St James's. If this is the only graph I have, I promise, and it really just shows our numbers. And these are all patients who have had a stem cell transplant for multiple myeloma. You can see the red graph, these are patients who've had 1 transplant, and the yellow graph are patients who've had a 2nd transplant. And as you can see, I just went back to 1998, but the numbers are gradually increasing every year. And we would do between 50 and 60 autologous stem cell transplants for myeloma in St James's every year. So how does that work? When do we hear about you? So I work with Professor Brown, who you spoke to this morning, and Dr. Patrick Hayden, who are the 2 consultants that treat and transplant patients with myeloma. So the referral comes from all the different centres. So whatever consultant is treating you in your referral centre will send a letter into either Patrick or Paul. More often than not, I am now CC'd into those letters. So as soon as I get that copy of the letter, or my nursing colleagues around the country will ring me and say, look, we have somebody that we want you to consider for a stem cell transplant. Once I get the letter, then I will book you into what we call our transplant counselling clinic. It's a very dedicated clinic where the consultants will see hopefully no more than 3 people per clinic to allow them to spend time with you, because it is a very detailed clinic. You get bombarded with information, and we like to be able to spend as much time with you as possible, that we don't have another 20 or 30 people in our usual clinics to see. There are 2 processes: peripheral blood stem cell harvest, PBSCH, peripheral blood stem cell transplant, and then obviously there's follow-up. Really, this is just diagram, really telling you what I've just spoke to you there about. So we've got to collect your stem cells, then we put them in the freezers. That allows us then to admit you, give you your high-dose chemotherapy, 2 to 3 weeks roughly in hospital, and then you're discharged and followed. So what happens in the counselling clinic? So our counselling clinics, as I said, they're run every week, and Dr. Hayden does his on a Monday afternoon, Professor Brown does his on a Thursday morning. And so it's a busy clinic. There are lots of other clinics running in conjunction with it, so don't get utterly shocked if you come into St. James's and there's huge queues there. You do need to register at our desk. I will have pre-ordered certain blood tests for you. Most of these blood tests are very same as what you're having done in your own hospital. Some of them are very specific to the transplant, and we got to do them in St. James's. We are governed by the European directive in relation to the storage of human tissue, and they tell us that we have to do certain bloods, and we have to do them with a certain period of time, and they have to go to a certain accredited lab. So that's why we do bloods in James's. A lot of people ask us, I've had bloods done in my referring hospital yesterday or the week beforehand, why do I have to have more bloods done? We do always like to have our own bloods on the system, so we can see how your myeloma is progressing, we can see your kidney function, we can see your bone marrow function. So once you have the bloods done, then either myself or the consultant, whichever happens to be free, will see you first. If I am pretty sure, and I've spoken to whichever consultant you're going to see beforehand, and I know that this is the treatment, that pathway that we're planning for you, then I can see you first and I can talk you through the pathway. But sometimes we swap over. But it normally works really, really well, and it normally flows really, really well. So you will have a medical review, and that is very much the core of the whole counselling clinic. Your medical history is taken. A lot of this review as well is to ascertain if we think you're fit enough to go down the route of a stem cell transplant. Some people are, some people are not. We say there's a cut-off age. Is there really? We say 65. Having said that, we've transplanted a 71-year-old already this year. So it really is, when we see you in the clinic, we will try and make that decision, even though at that stage it's not technically scientific, but we will do some tests before the transplant. But sometimes people walk in and we just know that, look, this is not the right thing to do, that we would probably do more harm than good, because it is pretty hard treatment, and we just want to try to the best of our ability that we're safe in what we're doing. My role at that clinic is to talk you through the process, is to plan the process for you, is to explain it, educate you. And we would do all that. Then whichever consultant, again, you're attending will go through a consent form with you. And it's a pretty detailed consent form. Again, we have a lot of different things that we consent you for, but we consent you really to allow us to give your cells to the cryobiology scientists. And they will freeze the cells first then. Without that consent form, we can't freeze your cells. The other thing we consent you for is data. We do submit information on every single patient we transplant in St. James's to the European Bone Marrow Transplant Registry. And that is hugely beneficial to us, because they feed back to us then every year, and they tell us the outcomes for transplant with patients with myeloma and all the other, obviously, diseases that we would transplant for. And there's always a little bit about research in most consent forms now, and you probably know stem cells are probably a very hot topic, and we will ask you if you're happy, if there's excess and only excess cells. If there is a research project in the future, if we're approached by Trinity or one of the universities in relation to doing some kind of research, and it might be research in relation to motor neuron disease or something like that, it may not be myeloma at all, and they want to use stem cells. So if you've signed that, then obviously we can use the cells that are excess for those purposes. Then we do very practical things. So to take your stem cells from you, we need to have very good venous access, and a lot of the time patients who've had a lot of treatment, their venous access is quite poor. So I will assess venous access. If I'm any way in doubt that the veins aren't good enough, I will call my apheresis colleagues to have a look, just simply because of the fact that they're the experts, they're the people that are going to have you on the apheresis machine trying to take your stem cells from you. If we think your veins in your arms aren't good enough for the harvesting procedure, then we would actually put a central venous access device. So it's a hard plastic tube that goes into one of the major veins here in your neck. It is put in under X-ray guidance. It is another procedure. We try and avoid it if we can. But to be honest with you, if we think we need it, we will absolutely put it in, because it's kind of torturous for you if we haven't got good venous access. When your stem cells, when we get them to move out of your bone marrow, they don't like staying out of your bone marrow for very long. So we have a very short window to grab them. And if we're struggling to get access the day that there is lots of stem cells in your blood and we can't get access, then we've lost that window of opportunity. That line can be put in your referring centre, depends on where you're coming from, or else we can get it put in locally in St James's. And normally we put it in the morning of the harvest. We have really good relationship with our interventional radiologists. And it should hopefully only stay in for a day. If we've collected enough stem cells in one day and we have a count back on the product early enough in the day, then we can remove the line. And it's like, the cannula in the back of your hand, it slides out, but it's just this uncomfortable tube in your neck. But more often than not, we can get away with just using your veins, but we need veins in both arms. What I would do then is I'll schedule the stem cell harvest, which is the first part, and I'll talk you through those dates. And then after once you've left, then we have to obviously talk to your referring team. So then what I would do is I'd write to whichever consultant in whatever hospital has referred you, and I'll write to my nursing colleague, the clinical nurse specialist, and give them the details. And really what I'm saying to them is, can you administer chemotherapy on such and such a date? Can you start growth factor injections? And I'm going to explain all of that to you. This person should be admitted to St James's on such and such a date. So they have all the instructions, and I give them my phone number. I also will write down for you what dates as well. So I give you out these wee booklets, and I don't know, some of you may have seen them and some of you won't, but they're available through the Irish Cancer Society, and they're booklets that myself and the team in St James's have written, and really it's just exactly what I go through with you on the day is written down here, and then I will also write in the schedule, so at least you have something in writing. So we've done all that, and now we're going to talk through the harvesting procedure itself. So your stem cells are your little blood cells, baby blood cells basically. They live in your bone marrow. And they normally stay within the confines of the bone marrow. Very few of them come out into your peripheral blood. And what we're trying to do to you is get lots and lots and lots of these little stem cells, which are a fascinating cell really, to push out of your bone marrow into your blood. And when they're circulating in your blood, then we can collect them through the thing called this apheresis procedure. But we have to move them, in other words, mobilise them, to get them to come from the bone marrow into your blood. And how do we do that? And the beauty of the stem cell is if we can capture your stem cells, we know each little stem cell has the amazing ability to change itself or proliferate, okay, and become any of your blood cells that you happen to need at any one time. So each little stem cell can decide, well, you know what, this person is short of white cells, I'm going to become a white cell and I'm going to flow out into the blood and I'm going to do what the white cells do. Likewise, it can become a platelet, likewise it can become a red cell. And they're the three main components of blood, without which technically we cannot survive. And once it makes the decision I'm going to be a white cell, it's more often than likely that is what it's going to be, it can't change its mind. So we know if we can capture white cells, then we can repopulate we can capture the stem cells, we can repopulate your bone marrow. And we have cells that will actually make all the blood cells that you require to survive. So we have to do something to you to get those cells to move out of the bone marrow. So there's two ways to do this. So we can give you chemotherapy and growth factor injection, or we can give you growth factor injection on its own. Chemotherapy and growth factor injection normally works better. And sometimes we would only go for growth factor on its own, depending on fitness status and bloods, and there's a few little things that would tell us that we should only use the growth factor. The chemotherapy is normally day ward therapy. Now again, that depends on what centre is referring you. We don't really dictate that to the referring centre, but it can be given as a day patient, and most centres are giving it as day patient. It's a 3-hour infusion of chemotherapy. It is strong chemotherapy. It's a lot stronger than any drugs you'll have been on to date, and you will have some side effects from it. It's a drug called cyclophosphamide. It's an infusion, as I said, it's a 3-hour infusion. We give you a couple of injections throughout the day to stop some of the side effects. One of the major side effects that can happen with the dose that we give you is it can cause some irritation to the lining of your bladder. So you're getting lots and lots of fluids throughout the day as well. So you're in and out of the loop Hiddlin, which is what we want you to be doing. And this drug called Mesnet just coats the lining of your bladder, so it hopefully prevents the irritation. Why that's important is because when you go home that night, we really, really want you to be able to be taking fluids and not to be nauseated and certainly not to be vomiting. Then the next day then you would start the little growth factor injections. So this is a drug which we recommend to most centres called Neupogen, or granulocyte stimulating factor. And what it does, it really is just telling your bone marrow to make stem cells. It's an injection into your tummy, and more often than not it will be 2 injections at a time, just because of the doses that we use. So if your pharmacy is giving you 2 injections, that is correct. And if they have any queries, because sometimes pharmacies do have queries about the dosing of this drug, you can always tell them to ring me, because it's really, really important that we get the growth factor dosing right. We have one chance to get your stem cells more often than not, so we want to try and do it properly. You can inject yourself, and most people do, and that gives you a little bit of freedom. The most important thing is that you take these injections every single day until somebody in St. James's has stopped and told you to stop taking them. So we continue them daily until we have your cells in the freezer. They come in a pre-filled syringe, and all you've got to do is take them out of the fridge for probably about half an hour before you give them to yourself, and just inject them into the tummy. And do take them out of the fridge, because if you don't, you will feel it, because if you give yourself an injection that's cold, you'll certainly feel it. But they're very easy to administer. If you don't want to administer them yourself, that's fine. We'll organise a public health nurse or a family member. And your local team will normally organise how that happens. And then normally, if you're getting the growth factor on their own, so if you're just getting the little GCSF injections on their own, they will normally just be about 4 days of those injections. So that's the cyclophosphamide and the chemotherapy. So if you get the cyclophosphamide on Monday, we would hope that about 8 to 10 days later, there is enough stem cells in your blood that tells us it's worth putting you on the apheresis machine. We don't put you on the apheresis machine willy-nilly. We wait to get that blood test. We don't want to put you through a procedure for no gain. So normally that's the following Tuesday or Wednesday week. We do try to admit you to St. James's for that, to facilitate the procedure, but a lot of the time, I'll be very honest with you, there isn't a bed because you're not technically unwell. So what we try and do is I try and admit you the weekend beforehand, and the admissions department are aware that you are hopefully going to get into a bed. If there isn't a bed and you've been well at home, then I ask you to come to our day ward for about 8 o'clock on the Monday morning. So that's the Monday of the week that we're going to hopefully harvest your cells. That's for 2 reasons. It's to allow me to take that very specific blood test, and also then, at least if you're in our day ward, I have a better chance of getting you into a bed. That blood test goes to the cryobiology lab, to the scientists over there. They're the team that will freeze your stem cells for us. And normally about 2 hours later, they will call me with a result. So they will ring and say, look, this is what the peripheral CD34 count is. And you'll hear us talking about CD34 cells. That's just the scientific name for your stem cells. And it depends on that result then, whether we think it's worth putting you on the machine that day, or whether, if we put it on today, we're not going to get what we're looking for. Let's wait and see what tomorrow brings. Obviously, if there's any query with the stem cell count, we'll run it by the consultant team. Mostly, though, it's the Tuesday or the Wednesday. And we don't want to put you on if we don't think we're going to get what we're looking for. But hopefully Tuesday or Wednesday after the chemotherapy. The growth factor on their own, then we normally start that on a Saturday. Again, it's 2 injections at a time. We would check what we call that CD34 count, your stem cell count, on the Tuesday morning after 3 doses of the injection. Don't expect there to be enough cells there at that stage, but sometimes there is, and that's why we check it. But normally it's the Wednesday, so it's normally 4 days of those injections. The procedure itself is tolerated really well. Most people, to be honest with you, are bored. You are in a room with probably one other person. There's at least 1 nurse, if not 2 nurses, with you at all times. You're sitting on a couch and you're connected to the apheresis machine, be it through a line in your neck or be it through veins in your arms. Hopefully 1 day is enough. But if we don't hit our target of stem cells, we know we have a target, that we have got to hit a certain number that it's safe to give you high-dose chemotherapy. If we don't hit that target, then we will put you on for a second day, again, if we think it's worth it. Very, very rarely now do we have to go to 3 days, and very rarely we have to go to 2 days. More often than not, we're getting what we want in 1 day of a harvest procedure. Normally takes about 4 to 6 hours. Again, that depends on the peripheral count. But we can kind of tell you, once we see the peripheral count, how long you're going to be with us and on the machine. The difficulty for you, though, is once you're connected, you're connected. And we really, really, really don't like to disconnect you. So, if you need to use the loo or anything, it's not the most pleasant. But hopefully, it's over and done with in one day. As I said, it can be done as an inpatient. Sometimes we do it as a day patient. And if you're coming to St. James's from the Mater Tala or Beaumont, then you're transferred over from those hospitals. This is a picture of a patient on an apheresis machine. Now, it's not St. James's apheresis machine, I might add, but it's as you can see, he's quite comfortable. You can see the red bag, that's your stem cells. And as I said, that really is the very same picture as what it's like in St. James's. Okay, so once we have your cells, that's the beauty of that, over and done with. So the cells go into the freezer. They can stay there for any length of time, really. We say we store them for up to 15 years, and at that stage then we will re-evaluate. But we will never destroy cells without checking with your referring consultant and without checking with the consultant, obviously, in St. James's that's looking after you. But normally, in this situation, we will do your transplant about 6 to 8 weeks after you've had your cells harvested. And a lot of things that, beds are a huge issue, as I'm sure are aware. So we do try and get you in within a timely manner, but sometimes the wait is just a little bit longer. So the unit that you're admitted to in St. James is called Dennis Burkitt. It is a purpose-built 21-bedded transplant unit. It's locked. It's not locked to keep you in. It's locked to keep the public out. And we had to do that because no matter how many signs you put on a door, people still walked in and out willy-nilly. And infection control is a massive, massive issue for you and for every other patient in the transplant unit. So I'll just give you a wee brief history of the unit. So basically we transferred over to the new unit in 1996 from a very old, dilapidated ward, but certainly served its purpose for many years. It's named after an Irish surgeon, an epidemiologist, which was brilliant, a guy who discovered Burkitt lymphoma while working in Africa. And as I said, it is 21 single isolation rooms. It's purpose-built, it's HEPA filtered, and the whole intent really is just to try and reduce the risk of infection to our patients. So you are in a room on your own. We are human. We do allow you to bring certain things in with you. We do allow visitors. But we do ask you to restrict visitors. There's 3 ways people can get infection: from yourself, from the environment, and from other people. So less people that come to visit you probably is better. The one time we're really quite strict on visiting is when we're coming into flu season. And we would very, very much ask you not to say to any relatives, please do not come anywhere near the transplant unit if you have any flu-like symptoms. So just all that has to be is a runny nose. I also encourage all relatives to absolutely take the flu vaccine, certainly coming into flu season. It is a huge worry for us, and flu is extremely serious in the transplant setting. The other bug, of course, this time of the year that we don't like to see either is the winter vomiting bug. Other than that, as I said, people can absolutely come to visit you, and we absolutely accept that from a psychological perspective, that you need visitors. It's open visiting, so you can come morning and evening. We encourage visitors not to stay at night, simply because of the fact we've nowhere for you to stay, and there is no need. The nursing team in the unit are amazing, and they will look after you while you're in there. But it's you can bring in mobile phones, you can bring in books. The cleaning staff in the unit are amazing. They'll pop up and down and get you the newspaper every day. We ask you not to bring in your own food. Again, we can't stand over it. If you get an upset stomach, is it something you ate that you brought in from home, or what is it? This is a picture of the unit. Having said that, the colours are now gone, and they've painted it back to the old clinical white again. This is one of the nursing team, one of the nurse managers in what we call the little ante-room leading into the unit. So again, it's all about hand washing. The room, as you can see, is very barren. Again, that was done purposely. There's no wardrobe space, for example, in the rooms. That was purposely thought about, because the less you have with you, the less dust it collects. So it is really important to have, obviously, a relative or a significant other there that can take home washing and things like that for you. There is Wi-Fi in the unit. Some days it's brilliant and more days it's not. There will be days certainly when you'll want to be using Wi-Fi. There'll be days where you won't have any interest in it. And again, that's Fidelma, and one of the staff nurses. Fidelma is the ward manager. So remember I was saying to you, we kind of look at you when you come into the counselling clinic just to try and ensure that what we're doing to you, we're doing it as safely as we can, and that you are potentially fit enough to have a transplant. So we do certain tests after your harvest, before the transplant. So we look at your lung function tests. Now, none of these are invasive tests, so it's not too difficult. You've got to just blow down some tubes for the pulmonary function tests. We do an echocardiogram, which is like an ultrasound of the heart. Dental assessment is really important, but that can be done with your own dentist. And really what I just want them to say to us is that from their perspective, they feel that you are dentally fit to undergo high-dose chemotherapy. And really what we're looking for is that there's no underlying dental abscesses or something like that that has never caused you a problem you've been totally unaware of, and then we give you high-dose chemotherapy. We really lower your ability to fight infection, and all of a sudden then you present a couple of days into your transplant with a huge big dental abscess. Your local own dentist can do that for us, and so you don't need to be worrying about having to see a dentist in a hospital or anything like that. Then we've got to insert some kind of a central venous access device. And a lot of the time the one we insert is the PICC line, which is it's a little rubber tube that goes into one of the major veins again in your arm. And it can facilitate all of your chemotherapy administration, all of your support administration. We take all your blood samples through it. So the beauty for you is that we don't have to stab you trying to get blood samples or anything like that from you anymore. That line can be inserted again locally, or we can get it done in St. James's the morning of your transplant. We do a 24-hour urine collection, which is a really, really, really important test. And it's telling us your renal function, your kidney function. And we absolutely dose your dose of the chemotherapy. We dose it on that result. Because the drug we give you is pretty tough and toxic to your kidneys. So that's a really important test, and sometimes we get it wrong in St. James's in the sense it's sent for the wrong test, or patients get it wrong, but literally we're just asking you to, every urine specimen you pass for a 24-hour period, you put it into a bottle, and when you take that bottle back into whatever hospital, you have to have a blood test taken on the same day. So, if that comes up and it's anyway worrying, then more often than not we will just get the referring centre to repeat that, just to be absolutely certain that that result is correct. Infection markers. So the things we're looking for here is, you've probably all heard of the MRSAs and some of the bowel bugs like the vancomycin-resistant enterococcus. We just ask your referring team to screen you for those bugs. If we know that you are a carrier of any of these, it doesn't in any way influence the transplant. It just means that we know when you become unwell or spike a temperature or show any signs of infection, that you are either resistant to this antibiotic or resistant to another antibiotic. So it just directs us and the medical team more so into relation to what antibiotics they need to give you at that stage. Chest x-ray, just to make sure that there isn't anything underlying going on in your lungs. And then an ECG, which is like the electrical charges in your heart. So once all those tests are done, they will be sent back up to me. These are just pictures of the central venous access devices. So it's the PICC line, it's the one in the arm that we use more often than not. Sometimes some centres, because of access difficulties or something like that, may not be able to get the PICC in, and they will put in what we call the little Hickman line, which is the one that goes into your chest wall. It's a little bit more difficult for procedure for you to go through because it is going in through the chest wall. But as I said, that's rare. But obviously, if we can't get the PICC line in, we will ask to put a Hickman in. And what we need is at least 2 lumens. 1 lumen is not sufficient because of the amount of traffic and supportive therapy that we give you during the transplant. So once I have all the tests, the next thing I have to look for is your stem cell verification. And my colleagues in the cryobiology lab then will send me that report. And that's a really, really, really important report. And that tells us that we do have enough stem cells to rescue you from the side effect of the high-dose chemotherapy. And those stem cells are going to do what we want them to do when we give them back to you. If you are being sent to St. James's from Mater, Tala or Beaumont, I will absolutely make certain that before those hospitals administer your chemotherapy, that they have seen that verification report. So I will always email that over to my nursing colleagues, and they will email me back and say, yes, we have stem cell verification. Are we good to go? And I will say yes. Likewise, the nursing team in the transplant unit, when I'm educating them, I always say to them, girls, under no circumstances, trust me or trust the consultant that has signed the patient off. You are administering high-dose chemotherapy. You have got to make sure that there are stem cells to rescue that patient. And that verification report will be there for them to look at. I will have it in your notes. Once I have the verification report and I have all the test results, then I sit down with your consultant and what we call sign you off. And we call it a front sheet. So it's just a document with all the test results on it, your name, your details, hospital number, your dosing of chemotherapy, what days you get your chemotherapy, and all the test results and the stem cell verification. So the consultant will sign that and I will sign that. So it's always double signed, just for a double checking procedure. And then that is put in your medical notes in the transplant unit. And as I said, once the nurses have that piece of paper, they are good to go. The drug we give you is a drug called melphalan. Most of you won't have had this drug before. It's given intravenously and it's given over 2 days. The dose will depend on the consultant that has signed you off. So sometimes we dose reduce. We normally give 200 milligrams per metre squared, but we can reduce down to 140. And a lot of time that depends on your fitness and on your kidney function. It comes in a syringe and the nurses in the unit will administer it. If you're asleep when the nurses gave it to you, you would be none the wiser. It comes in a syringe. It's quite a thick, viscousy kind of solution. So they just inject it in through a litre of saline that runs down through the PICC line into your arm. So I said you get it on 2 days. So we say we give it to you on a Wednesday and a Thursday. And then there has to be at least a 24-hour gap. And we're very strict on that as well. So we do document what time the last dose of melphalan is given. And then 24 hours later, and to be honest with you, more often than not, it's probably more than 24 hours later, we would give you the stem cell reinfusion. And again, stem cell reinfusion, guys, is a bit of an anticlimax because it's the transplant. And again, it really is like a blood transfusion. It's a kind of a pinky, watery, bloody solution hanging in a bag. Again, the nursing team will hang the bag on the drip stand, connect it into your PICC line, and the cells will just flow in literally like an infusion of blood. We give you an antihistamine and a steroid injection before we give you the cells back. You're not going to react to your own stem cells. They're going to be delighted, they're home, they're in familiar territory. But we do add a preservative to your cells as we're freezing them just to protect them. And sometimes you can get a little bit of an allergic reaction to that preservative. Just means that you might be a little bit sleepy-ish when you're getting the reinfusion. How long? It depends on how many bags of cells we're going to give you. But you're normally probably talking an hour, 2 hours at the most, and that's it. Your stem cells are reinfused and it's done. We call that day 0. And every day after that then is day +1, +2, +3, so on and so forth, okay? And this is just kind of telling you. So you come in, your blood counts are normal, as you can see up there at the top. We give you the chemotherapy. And probably about 2 or 3 days later, we see the blood count starting to drop. They will hit rock bottom for about 4 or 5 days. And then, again, you'll see the curve going back up again, and that's where your blood counts are recovering. So what happens when you're in? So the first couple of days, when you're on your chemotherapy, you are normally very well. Day 0, you're normally very well. Some people get a little bit of nausea kicking in at this stage. Normally about day +2, 3, 4, 5, 6 are what we call the rough days. And we do tell you what to expect, and the reason why we tell you what to expect is to hopefully to take the fear factor out of it, because it can be very frightening if you don't know that any of this is going to happen to you. And the worst toxicity of this is the chemotherapy. It's literally a direct side effect of the chemotherapy. We know it's high-dose chemotherapy. So what we wanted to do is to go after the bad cells, to go after the myeloma cells, and keep them quiet or destroy them to the best of its ability. But we know that it is going to attack some of the normal cells in your body. We know that because we've taken your bone marrow from you. So we don't worry awfully then because we know we have bone marrow to rescue you. But that takes time. Your new bone marrow cells have to kick in. And, you know, they take a little while. They have to find their way back into your bone marrow. They've lodged themselves there, and then they have to realise, you know what, we're here for a reason. We better start making blood cells again. The one side effect that is really difficult for patients is the sore mouth. And we concentrate probably on your mouth. We talk about your mouth, but a lot of the time it's not just your mouth. It is your gut. And it's because the chemotherapy has zoomed in on the gut and has attacked the lining of your gut. So it's this thing called mucositis, and it can be quite severe. A lot of our patients need morphine for that, and morphine frightens people, but please don't be frightened by it. We're using it in doses that you need to control your pain, and as soon as your pain is controlled, we dose reduce it very gradually, so there's no worries about addictions or anything like that with the doses that we're using. It means that if you have this sore gut, you don't want to eat, you don't want to drink, you feel nauseated, you have tummy cramps, and you have diarrhoea, and that does last for about 4 or 5 days, and it is not pleasant. And while all that is going on, of course, that's the time when your blood counts are at their lowest, so you're feeling at your weakest. It absolutely will improve once your new stem cells kick in and you start to produce blood cells. Your gut will start to heal. But for that intervening period, that 4 or 5 days, it is not pleasant. But please know it's normal and it will get better. As I said, the other major side effect then is obviously your blood counts are going to fall, and they're going to fall down to pretty dangerous levels, which they would be very dangerous if you weren't being nursed in a specialised transplant unit. So you will become what we call neutropenic, and that is when you have a very, very, very low white cell count. So your white cell count will probably drop to about 0.1, and what that means for you is that you are extremely susceptible. If you pick up an infection, you have nothing in your system to fight that infection. So normally what happens is if we get infection, our neutrophils rush to the bugs that are causing the infection and destroy them. You won't have that response. Again, while you're nursing the transplant unit. In this situation, the nursing team in the unit have policies in place that if they think you're starting to what we call become septic, they will initiate antibiotic therapy, they will take blood cultures, they'll order chest x-rays, things like that, and then they will call the medical team. Because a lot of the time, as you can absolutely appreciate, the medical team cannot be at your bedside 24 hours a day. So we've put all these processes in place to prevent you becoming septic. Anemia is when you have a low blood count, as in red cells. We can give you blood transfusion to bring that up. And the platelets are the blood cells that cause your blood to clot. Again, we can give you platelets. We can't give you white cells, unfortunately. We have to weather that storm because their lifespan is so short. They only live for about 7 hours. So we can't obviously take them from a donor and get them to a lab, get them from the lab to a hospital and reinfuse them. So we have to weather the storm of the white cells. But again, that takes about 5 or 6 days. Hopefully, about day +7, we will see that graph going back up again. And that's your new stem cells kicking in, realising they're there for a reason, starting to make new blood again. Fatigue is a huge problem. And it's an overwhelming fatigue. And when you go home, it's like as if you've been hit by a bus. And, you know, even to the extent that you're sitting in the chair and you think, I'd love a cup of coffee. And there's nobody with you and think, oh, I couldn't be bothered. And I just haven't got the energy to make it. It takes about 3 months to get over the fatigue and to get back to your good old self again. Having said that, there's a lot of time people ring and say, look, Liz, can I go back to work 2, 3, 6, 4 weeks, whatever, after the transplant? I'm going stir crazy here. It's not manual work. I feel like I could do a day a week, you know, psychologically. And we say, absolutely. You just have to listen to your body and do what your body allows you to do. But do expect to be fatigued. And unfortunately, nausea is that horrible feeling that makes us all feel rotten. We've great drugs to control vomiting. We've hopeless drugs to control nausea. And sometimes if you have that horrible nauseating feeling, you just don't want to do anything. But again, hopefully, once you get out of hospital, hopefully the nausea has subsided at that stage. So discharge then, basically, you're discharged to your referring team. If you're a St. James's patient, obviously you're followed up with us in St. James's. If you've come from any other centres around the country, we discharge you back to the care of your referring consultant. The door is always open in St. James's. The consultants in St. James's will always see you if you need to be seen, and you just need to contact us. But we don't give you follow-up appointments for St. James's. We allow the teams in the referring centres to follow you up, and that's partly because we don't need to see you. We certainly don't need to be dragging you up to Dublin if you don't need to come back, be dragged up to Dublin. We do look for information on you, though, from the referring centre. So we do ask them to send us data on your progress, so we know how you're doing it, so also we can send that information to the European Bone Marrow Transplant Registry. So once you're discharged, we do say we hope we never see you again, but we mean that in the best possible way. But as I said, our doors are always open, and you will have my phone number, and you can always ring. And if there's a problem, I will talk to whichever consultant you're under, and they will see you. There's never a problem that way. And that is the pathway for a transplant. If anybody has any questions or comments, yeah.